Bismillahirrahmanirrahim. Assalamu alaikum. Welcome to the channel. This is in continuation of the series of lectures regarding the diseases which can affect the nasal septum. So today we are going to talk about another entity which is called as septal perforation. So let's start today's discussion. You are requested not to forget subscribing the channel so you are not going to miss important topics. Nasal septum, as we know from our anatomy knowledge, it is composed of osseo-cartilaginous framework. Anteriorly is septal cartilage, which forms almost 1/3 of this framework, which we call as quadrangular cartilage. Then posteriorly is the perpendicular plate of the ethmoid, and postero-inferiorly is the vomer, and the septum is attached to the crest of maxilla and palatine bones. As in this picture you can see, this is the anteroinferior part, which is composed of septal cartilage. Then postero-inferiorly is the vomer, postero-superiorly is the perpendicular plate of ethmoid, and minor contributions are from rostrum of sphenoid, then this crest of palatine bone, crest of maxilla, which forms this anterior nasal spine of the maxilla as well, and then there is crest of nasal bone and nasal spine of the frontal bone also contributing in this nasal septum framework. Nasal septum is divided into three parts basically. One is columellar septum, the most caudal part, which is consisting of medial crura of the lower lateral cartilages along with the skin folds. Behind that, the cartilage is deficient, as you can see here in the diagram as well, where the cursor is moving. This is called membranous septum. Here only the mucoperichondrium is there on both sides, and in between the cartilage is deficient, and then is the nasal septum proper, which we just mentioned. Now this septal perforation is concerned with the basically the ischemia, and it causes the ischemic necrosis. Any disease, as we will see in the etiological factors, there are so many causes which can cause the compromised blood supply, leading to the necrosis, which will be ischemic necrosis of the underlying cartilage and the bone. So the blood supply, you must be well aware of that this is from internal carotid system and this is from external carotid system. And blood vessels, there are basically four major vessels. One is anterior ethmoidal, and then is the posterior ethmoidal arteries. These two are the branches of ophthalmic artery, which is originating from the internal carotid artery. So anterior ethmoidal and posterior ethmoidal, these are the branches from the internal carotid system. External carotid, it gives maxillary artery and facial artery. The branches of the facial artery, which is basically the septal branch of superior labial artery, that supplies the anteroinferior part. Superior part is formed by this internal carotid system, and posterior part, it is supplied by the maxillary artery mainly. This is anteroinferior part is the Little's area, there where there is Caselbach's plexus. We have talked about it already in detail. You can check it out from the video about anatomy of internal nose. The link for that is there in the description as well, along with the other diseases which we have already covered, like septal hematoma, septal abscess, nasal synechia, deflected nasal septum, fractures of the nasal septum. All the links are there in the description box. We know that cartilage is a vascular structure anywhere in the body, and it gets its blood supply from the overlying mucoperichondrium. So same is the case for the bones there in the nasal septum, which gets its blood supply from the overlying mucoperiosteum. So any insult or any event which, for example, it can be a chemical insult or physical trauma or iatrogenic trauma to the nasal septum, which can jeopardize the blood supply of the underlying cartilage, which can lead to ischemic necrosis. And on examination, this is how you can see a septal perforation in the cartilaginous portion of the nasal septum. Usually, the septal perforation, or most commonly, it is seen in the cartilaginous portion of the nasal septum. In syphilis, which is a chronic granulomatous infection of the nose and paranasal sinuses, there is bony part of the nasal septum is usually involved in case of syphilis. Usually, or mostly, or most common cause of septal perforation is iatrogenic, which can be a complication of septal surgery, especially when SMR used to be very common. So that was a very common cause for septal perforation. Or it can be due to nose picking as well. Many perforations which used to be considered as idiopathic, actually they are thought to be due to nose picking, though there may not be any clear-cut history and patient may be denying of nose picking, but still underlying factor will be this nose picking. Perforations, these usually are preceded by ulceration, that there will be ulcer, so that there is break in the mucosal lining, compromising the blood supply of the underlying cartilage or bone, and later on there will be ischemic necrosis, and then there will be a through and through defect in the nasal septal cartilage. Except in case of septal hematoma or abscess, where there is collection of blood or pus between cartilage and mucoperichondrium. So blood supply is again compromised in that situation. The frequency of nasal septal perforations is correlated with the number of nasal septal surgeries. As I just mentioned, most common cause is nasal septal surgery, that is SMR especially. This incidence has got no geographical correlation, and condition is not clearly and directly associated with age, sex, diabetes or smoking. So in any age, at any sex, and whether underlying diabetes is present or not will not affect the incidence of or frequency of septal perforations. In Swedish population, they revealed that 0.9% prevalence of a septal perforation. As far as the etiology is concerned, as I just mentioned, that iatrogenic trauma is the most common cause, and then there can be different kinds of trauma. As we know, out of that trauma group, iatrogenic is the most common. Again, that is related with the septal surgeries, especially SMR or septoplasty, or there can be if nasal cautery bilaterally frequently is done for the control of, say, epistaxis. Then trauma can be with nose picking, that is self-inflicted trauma, or there can be other injuries like assault, road traffic accidents, or sports injuries that can lead to compromising the blood supply of the cartilage and ultimately resulting in the septal perforation. In addition to trauma, there can be other causes for septal perforation like different chronic granulomatous lesions, for example, syphilis, tuberculosis, leprosy, then neoplasm, as squamous cell carcinoma is the most common. In addition to that, other carcinomas like adenocarcinoma, basal cell carcinoma, or Stewart's granuloma, that is T cell lymphoma. Then inflammatory causes, granulomatous lesions again of unknown etiology like Wagner's granulomatosis, periarteritis nodosa, systemic lupus erythematosus, which was abbreviated as SLE. If a patient is working in some industrial area where there are fumes of different gases, and due to inhalations of these irritants, there can be septal perforation like chrome, arsenic, alkaline dust, then drugs, especially the cocaine abuse, where they sniff these drugs and they are addicted to that, that can lead to chemical trauma of the nasal septum. Still, a large number of cases will be labeled as idiopathic, and as I just mentioned before as well, out of this idiopathic group, still so many will be actually due to the nose picking. Hard work at the end of the day pays off. There is no shortcuts in life, keep in mind. So it can be asymptomatic, that a patient has come to you and during routine examination it may be an incidental finding and patient even may be unaware of that. Then there can be recurrent nasal bleeding because of at the edges of the perforation there will be crusting and dryness in the nose, and when these crusts are being peeled off there can be bleeding from the nose. It can cause nasal obstruction. Then according to the size and position of the perforation, larger the perforation, more anterior its position, worse are the symptoms. And a very small perforation may cause whistling on respiration, because we know that when air is passing through a narrow space there is always a hissing sound. So a small perforation, there will be a hissing sound or whistling sound on inspiration especially. So this is how it will look like. Even to confirm it, you can pass this Q-tip from one nasal cavity and it will be protruding through the defect into the other side of the nasal cavity. This is that we are looking at the nasal cavity from right nasal cavity. There is a gap or perforation in the nasal septum, and through that perforation we can see the lateral nasal wall on the other side, and this is the left inferior turbinate. So while looking from the right nasal cavity, this left inferior turbinate is visible through this septal defect. Now, investigations will depend upon person to person or patient to patient and according to their presentation. For example, a patient comes to you with a history of septal surgery, and then you examine and there is a septal perforation. So that is a clear-cut diagnosis and no further investigation is required. But as we have seen in the etiological factors, that in addition to surgical trauma, there are so many other chronic granulomatous lesions, for example, can be a cause, or there can be neoplasms which can be a cause. So history and clinical examination will give us a clue, and according to that clue we can advise or request for different investigations. For example, we can go for blood test and with ESR, which will be raised in case of say vaginous granulomatosis or tuberculosis or any other granulomatous lesions or chronic infections, it will be raised. Then if we are suspecting tuberculosis, sarcoidosis, vaginous granulomatosis or even metastasis from some primary tumor, we can advise for chest radiograph and there will be findings on that. So again, I am reiterating that it does not mean that all these investigations will be ordered in each and every patient. No, it will depend upon history and clinical examination, and according to the provisional diagnosis, according to the clues which we will get from history and clinical examination, we will request for these investigations. So in case of vaginous granulomatosis or polyarteritis, for hematuria or proteinuria, we can ask for urinalysis. If we are suspecting syphilis, then we can go for treponema, fluorescent treponema antibody, that is FTA, and VDRL, that is venereal disease research laboratory test to confirm the syphilis. In case of vaginous granulomatosis, anti-neutrophil cytoplasmic antibody test, which is CANCA, is pathognomonic. Then in case of suspicion for fungal infections or bacterial granulomas, we can go for nasal cultures. CT scan of nose and paranasal sinuses will show us the extent of the disease in case of granulomatous or malignancy, and a biopsy from the edge of the perforation if there is suggestion of a neoplasm or a granuloma. So this is how a perforation will look like on anterior rhinoscopy. We can advise for barium paste as a contrast to localize the septal perforation, or we can go for CT scan and we can see that there is a defect which is through and through. This is what we call as septal perforation. Now, as far as the treatment is concerned, medical management of septal perforation will be prevention in patients at high risk of developing perforation, assessment of the cause and removal or minimization of that cause, and efforts to minimize the symptoms in established cases. So first objective is to cure the causative disease. For example, if it is due to tuberculosis, we have to go for anti-tuberculous treatment for 6 months regime or 9 months regime. If it is a malignancy, we have to deal with that according to the TNM staging of that malignancy. If it is Wagner's granulomatosis, the treatment for Wagner's granulomatosis we have to go for. Then locally, we can advise the medical treatment with 25% glucose in glycerine drops, which will loosen the crust rather, and it will be softening the crusts and easy to remove those crusts without laceration of the mucosa and the bleeding. Then we can advise the patient for nasal douching with saline, so that again there is no dryness and the crusts are not being formed, or if some crusting is there, that will be softened and it will be easy to remove those loosened crusts. Nasal emollients can also be used in the nose. Then if there is repeated bleeding or there is granulation tissue along the edges of the septal perforation, that can be cauterized with silver nitrate cautery, that is a chemical cautery. Perforations, according to their size, they are classified into 4 different groups. Group 1 is called as small perforation, and when it is the small perforation, we will label it when length of the perforation is less than 1/4 of the total vertical nasal septal length. Group 2 is medium perforations, when length of the perforation is larger than 1/4 but less than half of total vertical septal length. And in group 3 we label it as large perforations, when the length of the perforation is larger than half of the length but less than 3/4 of the total vertical septal length. And group 4 is very large perforations, when length of the perforation is larger than 3/4 of the total vertical septal length. Surgical closure of the perforation is very difficult to achieve. A variety of operations including use of split skin grafts, septal mucopericontial flaps in case of small perforations, especially when it is available, or we can take these mucosal flaps from the floor of the nasal cavity or even from the surface of the turbinates, and they can be transpositioned there over the nasal septal defect. Composite grafts from the pinna and even the septal cartilage can be used to bridge the gap in septal perforation. But if still perforation continues to trouble the patient, it is worth trying to plug the hole with a commercially available Silastic septal button. I just come to the details of this Silastic septal button in a while. So this is how we can measure. This is the vertical measurement of the septal perforation with a measuring tape, and this is the horizontal measuring. So according to the vertical length, we classify this into small, medium, large and very large size perforations. And after measurement, then if we have to go for this, for example, we have to put a cartilage graft there, so we know how much length of this and width of this cartilage is required. Then is the conservative approach, that nasal septal prosthesis, which is called as a Silastic button. That is the most conservative approach. It may serve as a temporary or long-term solution, especially in those patients who refuse the surgery or may have a comorbid condition, that, for example, malignancy, that precludes them from undergoing surgical treatment. This prosthesis It has been available there since 1970, and this is an placement of this prosthesis. This is an outdoor procedure, and in the clinic we can insert this plastic button very easily. These prostheses, they are available in a variety of materials. For example, acrylic. They can be made of plastic, and usually the material which is used for that is silicone. And basic design is that there are two flat discs, as you can see. These are in pairs, and in between these two are being connected by a central solid hub. So it is just like, you can say, a cuff link which we use for our shirts. So two flat discs with a solid hub in between. So these two flat discs will be on either side of the nasal septum, and the central hub will be connecting these so that the septal perforation is being closed. So follow-up will depend upon the cause. For example, for tuberculosis, we have to follow up and continue the treatment at least for 6 months. Then it will depend upon the severity of the symptoms, then treatment offered to the patient. With the elastic button, the patient should be on regular follow-up for 4 to 6 months to decrust and clean the prosthesis. Still, there can be problem with this septal prosthesis, and failures are due to that either the prosthesis is poorly fit, it is not of proper size according to the perforation, or patient intolerance is there, patient feels discomfort, or poor hygiene is there which leads to repeated infections. Then they occur usually within the first few months, all these problems. And if it is of smaller size and it keeps on moving, so the mobility of the button, it may lead to enlargement of the perforation. Potential post-operative complications of the surgery, they may include repeat perforation, then vestibular stenosis, nasal deformity, or oronasal fistula. So this was a brief description about septal perforation. Thanks for watching, and don't forget to subscribe the channel.